Hello, in this video, I'm going to talk about gait distortions. And by that, we really mean abnormal gait patterns that you might observe when doing a gait assessment. So shorten step length and stance time. So shorten step length. So when we're taking shorter steps and we're not traveling as far per step, it may occur in response to pain or weakness at any point throughout the kinetic chain. So it could be that the person is having a hard time maintaining stance on the stance leg to support a longer step. That's a common cause, but it could be pain or muscle weakness that could happen at different points in the kinetic chain during the gait cycle that would result in a shorter step. Shortened swing time could be due to inadequate push off by the plantar flexor muscles. So when we're pushing off to start the swing phase, there might be inadequacy in the muscle contraction there. Or it could be inadequate acetabulofemoral flexion. So if you can't flex the hip well enough to swing the leg through, that could result in a shorter swing time and a shorter step length ultimately. Shortened stance time could be because there's pain on the weight-bearing side, so they might be avoiding weight bearing, which again would also shorten swing time on the other side and shorten step length. So it can cause injury and pain due to compensations in other part of the kinetic chain. All right, so on to some very specific gait patterns, gluteus medius and maximus gaits. Pelvic drop is when the pelvis on the side of the swing leg drops during the swing phase of gait. So in the last video, we talked about how the pelvis does need to move up and down, front, back, and side to side. But when we're in mid stance on the stance leg, we want the pelvis to remain pretty stable. It might go down slightly on the swing side, but we want it to remain pretty stable. And gluteus medius is the muscle that maintains that position of the pelvis. Okay, so if gluteus medius is weak or it's not activating correctly, it will allow the pelvis on the opposite side to drop during swing phase. So it could be caused by difference in leg length, so if one leg is longer than the other, but more often it's caused by gluteus medius being weak on the stance side, so it's not able to pull up on the pelvis to maintain its level. So a gluteus medius gait is also referred to as a Trendelenburg gait. So it's pelvic drop caused by weak gluteus medius. Gluteus medius can't maintain the position of the pelvis, so it's able to drop on the other side. So the person will lean the trunk to move the center of gravity over the weak muscle. That's how it always works. So anytime someone has a weak muscle in gait, so like a lower extremity muscle, we lean our center of gravity on top of that weak muscle to reduce the need for that muscle to contract to stabilize our position. Okay, so if you think about with gluteus medius, the further, like in this picture, we're looking at the posterior side and we're looking at the right gluteus medius. The further our center of gravity is to the left side, the greater amount of force gluteus medius would have to contract to pull the pelvis up and pull the center of gravity more towards the center. So if the gluteus medius is too weak to do that, the solution is we lean our body weight on top or toward that weak muscle, and then we can produce less and less force and still maintain a functional gait. Okay, so that's true really whenever we have weak muscle. So weak hamstrings, we'd lean back, weak quadriceps, we'd lean forward. So we're gonna lean so that our center of gravity is as on top of the weak muscle as we can, because it reduces the requirement for that muscle to produce force. Okay, so a gluteus maximus gait. So when glute max is weak, that results in a lack of control during mid stance. So like I said, we shift our body weight over the weak muscle. So if glute max is weak, then we lean backwards. So trunk shifts posteriorly during heel strike, so that we get our center of gravity over glute max, which in this case is the weak muscle. So in general, center of gravity shifts during gait over whichever muscles are weak to reduce the force that the muscle is required to produce. So if you can keep that in mind, that will explain a lot of things that you observe in abnormal gait. So whenever someone is leaning like forward or back or to one side or the other, always be looking for weak muscles toward on the wherever they're leaning toward. And it also, of course, could be like pain avoidance or other things that could cause them to lean like that. But if there's no injury or pain or anything like that, be looking for the weak muscles that in the direction that they're leaning. So quadriceps weakness, I'm sure you could predict what that gait would look like. Similar to abnormal gaits caused by muscle weakness, where the person in this case is going to lean anteriorly at the beginning of stance phase to shift center of gravity over the weak muscle and force the tibiofemoral joint into extension. Okay, so if quad is weak, then they're gonna have a hard time getting the knee into full extension at the appropriate times during gait. Glute max and gastroc may also activate to help with the tibiofemoral joint and extension during heel strike. If the hamstrings are weak, the tibiofemoral joint may hyperextend during stance phase or shift into full extension during the terminal swing phase. Okay, now for all of these gaits, I'm also posting links to very short video clips. So if you look in Moodle under the lectures, you'll see these lectures that I'm recording, and then under that links to several other videos. So I would like you to watch all of them. They're just very short clips. Most of them are like 30 seconds long, so that you can see examples of these gait patterns because, you know, I could describe this all day, but it's better to have a full visual of what it looks like from the video. So please make sure that you watch those too as part of this lecture series. Equinus gait, drop foot, and steppage gate. They're all related, caused by very similar problem, which is why I grouped them together here. So in the case of talocrural dorsiflexor weakness, okay, so really tibialis anterior is the primary one there, the foot lands flat on the ground instead of a normal heel strike. So it's hard to get a normal heel strike if we can't properly dorsiflex. And so if we can't properly dorsiflex, that's where we get these three types of gait patterns, depending on what else the rest of the kinetic chain is doing, determines which of these three it is. So depending on the activation of the plantar flexor muscles, the result could be Equinus gait, drop foot, or a steppage gait. All right, so starting with Equinus. Equinus, like equine, like a horse. So it's sort of a horse kind of gait. The talocrural joint plantar flexes so that the toes strike first. So instead of a heel strike, we're in plantar flexion and the toes strike first. This is like a toe walking sort of gait. If the dorsiflexor muscles cannot support the body weight at or immediately following heel strike, then the foot may also slap the ground. Okay, so it might be toe walking with a foot slap. Okay, and again, watch the video. You'll be able to see really clearly what the difference is between these. Drop foot is when the talocrural joint plantar flexes during the swing phase due to dorsiflexor weakness. So Equinus, we really see at heel strike because they're forefoot striking instead of heel striking, and not in like a forefoot running type way, like not in a normal, healthy, selected gait. It's clearly abnormal and different from a normal forefoot running type of gait. So make sure you watch the video, you'll be able to see that. Here, the plantar flexion is during swing, which also will interfere with heel strike and shifting into the stance part of gait. Okay, so talocrural plantar flexes during the swing phase due to dorsiflexor weakness. Usually this one is caused by damage or dysfunction to the common peroneal nerve supplying the dorsiflexors of the ankle, or paralysis of the muscles of the anterior leg. Okay, so this is usually a nervous system problem. This is usually dysfunction of the nerve or motor control problem of those dorsiflexor muscles. So in the picture, like we're not even in gait and you're witnessing the inability of this person to dorsiflex, and so that this is drop foot that we're seeing. All right, a steppage gait is when drop foot causes the acetabulofemoral joints to achieve a greater degree of flexion to lift the knees higher so the toes can clear the ground. So in drop foot, we're in plantar flexion during swing. That's not good because normally during swing, we're more in a neutral position and then achieving greater dorsiflexion as we go in for heel strike. So if the foot is dropped and we're in plantar flexion during swing, we have to lift the whole limb higher as we swing through so that the toes can clear the ground. So that causes a steppage gait. So this person would have to have greater hip and knee flexion to get the toes to clear the ground because they're not dorsiflexing sufficiently. So then you get that high stepping. Okay, a waddling gait. Think back to if we have weak muscles, we shift our body mass on top of those weak muscles. Now imagine lots of things are weak all at the same time. So we have several groups of weak muscles. The shoulders might drift posteriorly compared to the hips. So this person usually is going to appear really upright or maybe even leaning back a little bit. Each side of the body will swing forward together to take each step. Upper extremities move posteriorly as the lower extremity moves forward to take a step. So it's just this kind of full body side to side waddle as opposed to the normal kind of upright alternation of left and right arms with opposite of left and right legs. So instead it's like the whole body is kind of waddling and there's a lot of lateral side to side movement as they take each step. So this imbalanced movement causes instability of the pelvis, hyperlordosis of the lumbar spine, and often there's a Trendelenburg gait. So there's a drop due to a weak glute medius on the stance side. Okay, so this waddling gait would be because lots of groups of muscles are weak, and so as they're moving, they're constantly shifting their center of mass onto the stance leg and swinging that whole side of the body forward. So again, watch the video. It will definitely help. All right, an asymmetrical arm swing could be caused by an upper extremity injury. So like if somebody has a shoulder injury or frozen shoulder, or they're recovering from something, or they have something going on in the shoulders, that could cause an asymmetrical arm swing. If there's an asymmetrical arm swing that is unrelated to any upper extremity injury, like everything is healthy and it's just a matter of abnormal gait, then it's a reflection of what is happening in the pelvis. Okay, so the arms swing opposite the pelvis, the movement of the pelvis. So more arm swing is reflective of more pelvic motion. Restricted arm swing is reflective of restricted pelvic motion. And then if it's asymmetrical, like one side is swinging a lot further forward or going more in abduction or whatever it is, if it's asymmetrical in the arm swing, then the pelvic motion is likely asymmetrical because the arms are counterbalancing the motion of the pelvis. Okay, so look for asymmetrical arm swing, and that will give a lot of information about asymmetry in the pelvic motion. Okay, so the arms are swinging to counterbalance movement of the hips during gait. Abnormal hip movement generally leads to abnormal arm swing. But again, you first have to rule out the possibility that there's an upper extremity injury or pain condition or range of motion problem or something in the upper extremity that could be causing that. Because in that case, that supersedes the counterbalancing action of the hips. Difference in leg length and spinal deformities could also cause arm swing to be asymmetrical. So the leg length, it's really because it's causing asymmetrical pelvic motion, which causes asymmetrical arm swing. But then if there's spinal deformities like scoliosis, for example, then that also can cause the arms to swing asymmetrically. All right, flat foot at heel strike or toe off. All right, so flat foot at heel strike, the person might have sprained ankle or a triceps surae tear that they might be avoiding pain or avoiding further injury. Like it might feel uncomfortable for them to dorsiflex, like have full range of motion into dorsiflexion and plantar flexion. So they might be restricting that motion. And as a reminder, triceps suri, I'm referring to the combination of the two heads of gastrocnemius plus soleus. Altogether makes 3 heads, as in triceps, and suri, the sural region, is the calf. Okay, so the person might have a sprained ankle or some kind of ankle pain or injury, or a tear in one of those, in gastroc soleus both, or the calcaneal tendon or something. And that could be causing them to avoid full range of motion at the joint. They'll move the center of mass over the foot quickly and initiate swing phase early to avoid plantar flexion. Okay, so that's an example where we might have shortened stance phase because they're trying to avoid weight bearing and they're trying to go back into swing phase quickly so they don't have to plantar flex and hold their body weight in plantar flexion. Flat foot at toe off, so when the foot is leaving the ground, could again be triceps suri weakness because we don't have enough, we can't produce enough force to push into plantar flexion and push off at toe off. Could be ankle sprain or forefoot pathology like bone spurs, or like a fracture in the metatarsals, or a intermetatarsal neuroma. Things like that could happen in the forefoot that could prevent the person from wanting to put too much force through that forefoot. So they'd be avoiding forefoot contact. Okay, so muscle imbalances during stance and swing. Excessive flexion of the tibiofemoral joint at heel strike could be caused by lots of different things. So too much flexion when the heel is hitting the ground could be that there's a tear, hypertonicity, or spasm of the hamstrings. So in that case, we wouldn't be able to fully extend the knee because the hamstring wouldn't be able to lengthen to a sufficient point. There could be sciatic nerve pathology. So that could be herniated discs that's impinging the sciatic nerve. It could be piriformis syndrome where piriformis is impinging the nerve. Or it could be actual damage to the sciatic nerve itself, not just an impingement condition. But the sciatic nerve is running down the whole posterior part of the lower extremity and controlling the hamstrings. So pathology of that nerve could interfere with the ability to fully extend. Hip adductor muscle tears could interfere. And the person will avoid full knee extension to protect the hamstrings and hip adductor muscles. So if those muscles are hypertonic, or if there are tears or some kind of injury, then somebody might stay in excessive knee flexion at heel strike because they're trying to protect those muscles, because it may feel like if they do go into full extension that they will tear the hamstrings or the hip adductors. That may not be the case, and they may not be consciously aware of that, but that might be the sensation in their body, and so they're altering their gait to protect those muscles. Okay, muscle imbalances during stance and swing continued here. So inadequate flexion of the tibiofemoral joint during stance. Okay, so inadequate flexion, like we're locking the knees out during stance, could be caused by a tear, hypertonicity, or spasm of the quadriceps, because its ability to control flexion eccentrically is reduced. So we're not able to control flexion. So we haven't talked about eccentric contractions yet, but that is just referring to the contraction of a muscle as it's lengthening. So if it's not able to do that well, it won't be able to control knee flexion very well. So instead, we might just not go into flexion. We'll lock out the knees. With or without quadriceps involvement, flexion during stance may be limited by tibiofemoral joint pain that restricts range of motion. So someone might have knee pain that's more comfortable when they lock out the knee or keep it fully extended, and flexing the knee too much might be painful. Okay, inadequate flexion of the tibiofemoral joint during swing phase could be caused by hamstring pathologies that limit flexion during swing. So if hamstring isn't contracting normally, then it might not flex the knee sufficiently during swing. Inadequate acetabulofemoral extension at heel off. Okay, so heel off, when we're moving past mid stance, the heel's coming up off the ground. So, and then we don't flex or we don't extend the hip sufficiently, could be caused by contracture of our hip flexor muscles. So the hip flexor muscles being in a shortened position could keep us in hip flexion and interfere with our ability to fully extend the hip. Okay, a forward trunk angle, so that's forward flexion of the trunk, could be caused by herniated discs, where essentially with a herniated disc or some kind of spinal injury, we might lean our center of mass forward so that the center of mass isn't going down through the spine. A normal healthy spine, we're designed to have the center of mass and the force go through the spine and for it to be stacked so that it could tolerate the forces. But if it can't do that because we have a herniated disc or some kind of spinal injury, we will lean forward to move our center of gravity in front of the spine, so because it takes that pressure off from the intervertebral joints. Could also be caused by weak or painful hip flexor muscles. So again, we move on top of the muscles that are weak and our hip flexors are in the front, so we'll lean forward. It could also be painful hip flexor muscles, so it might hurt for them to be more extended if we're leaned back, so we'll lean forward into a shortened position. Weak plantar flexor muscles, and that's harder to explain. Weak plantar flexor muscles, because the more we're stacked on top of the plantar flexor muscles, the more force they have to produce to propel us forward. So if we're leaning forward, they don't have to produce as much force to propel us forward because we are already forward. I hope that makes sense. The trunk becomes increasingly upright as speed of gait increases. So someone who does have a forward trunk angle, who is not more upright like most of us usually are, that angle will be more extreme at slower paces, and they'll become more upright as that speed increases. Okay, a toe in or a toe out gait. A toe in gait is just referring to the toes are pointed in towards one another, and toe out, the toes are pointed out away from one another, like we see in the picture here. So in a toe-in gait, there's forefoot adduction. So the 4 feet are toward the midline, and that stresses the lateral soft tissues and could cause lateral leg pain. And by leg, here we're referring to between the knee and the ankle. It's the anatomical region that is the leg. It's just knee to ankle. So that toe-in gait might put a lot of stress on that lateral part of the leg and cause soft tissue pain there. Toe-out gait is forefoot abduction, causes hyperpronation and stress on the medial and plantar foot. So either one, whether they have toe in or toe out gait, we would see that during gait at the mid stance and or toe off part of gait. And it could be caused by malalignment. So maybe the joints and the bones aren't in the proper place, or it could be muscle weakness in the kinetic chain. And that malalignment, it could be because things aren't in the proper place, or it could be like a congenital abnormality, like the way just the bones grew, the way the bones are designed and shaped. So it could be that, so structural, or it could be functional in terms of muscle weakness and not being able to control the function or position of the whole kinetic chain. Okay, a vaulting or circumducted gait. Again, these are different gaits, but I group them together because they happen in the same situations. A fused knee causes the entire lower extremity to remain at a fixed length. So if someone has had a knee fusion, so like a surgery where they fuse the bones together, we lose that hinge ability of the knee. So we lose the ability to flex and extend the knee when there's been a knee fusion. So we have 2 solutions to that. So there's no tibiofemoral flexion or extension permitted at the joint. And we have 2 solutions. That would be vaulting gait or circumducted gait. So in a vaulting gait, plantar flexion of the talocrural joint of the stance leg when the side with the fused knee is in swing phase. All right, so when a leg is going through in swing phase, we need to flex the knee so that we can lift the toes high enough and the foot clears the ground in normal gait. If we can't flex the knee, Then in vaulting gait, in the stance leg, the person's going up on their toes in plantar flexion so that they have enough room to swing the totally extended leg through in the normal path. That's a vaulting gait. So like they're lifting up and vaulting through with each step. They might also elevate the hip on the side of the swinging leg. Okay, so they're going up on the toes in the stance leg and lifting the hip on the swinging leg to make room so the toes can clear the ground. In a circumducted gait, that's what we see in the picture here. Instead of lifting and trying to get high enough for the leg to go through, instead of that, they're swinging the leg around so that they're making room and allowing the toes to clear by swinging it out to the side. So the extremity with the fused knee arcs laterally during swing phase before returning to the midline for heel strike. So that lets the toes clear without having to elevate the extremity. A Parkinsonian gait is exactly what it sounds like. It's a gait pattern displayed by someone who has Parkinson's disease. So it includes several very classic features of Parkinsonian movement. So it's reduced movement, especially in arm swings. So they'll keep the arms in and shuffle. So it's a shuffling gait where there isn't a lot of leg swing time and there isn't a lot of arm movement. So it's a shuffling that includes a lot of flexion. So flexion of the elbows, flexion of the waist, flexion of the knees. So there's a lot of flexion, a forward trunk angle, so the body weight is shifted forward under the forefeet. So it's kind of a shuffling gait on the forefoot with a lot of flexion and not a lot of swing for both arms and legs. An ataxic gait is a gait that would be displayed by somebody who's had some kind of cerebellar damage. So our cerebellum is critical for comparing our movement plan with the actual movement that our body is engaging in. So we compare the plan with the actual and then make corrections for whatever the difference is between the two so that we can smooth and coordinate our movement. So if somebody's had cerebellar damage that severely affects the person's ability to have smooth, coordinated movement, including in gait. So an ataxic gait would be uncoordinated. It would include jerky movements because we're not able to smooth them. Poor balance, staggering, swerving, and other evidence of reduced cerebellar function. So it would just be a gait pattern where we have a really difficult time executing our motor plan in a clear, effective, coordinated way. So they would be able to walk, they would have the movement plan, but they wouldn't be able to correct for the errors in that movement plan to smooth out gait. Okay, so that is all I have for you in this video. Thanks for watching, and I'll see you for the next one. Bye.